Okay, we are going to start, and the subject today is coronary artery anatomy. We are having trouble getting the cines to loop, so I'm going to modify today. Usually I break up left coronary and the right coronary. We go through anatomy, and so today we'll try to do both with anatomy, and then on the next talk spend the entire time on the angiography. But I think you'll be able to get as much from what we're going to do with the model than from the image. So what do we have here? We've got ice cream cone. And what do we have here? We have another ice cream cone. And believe it or not, you put two ice cream cones together and you have a heart. And one of the problems with viewing coronary angiography is the seeming complexity of the anatomy. Vessels go this way, vessels go that way, and you wind up trying to memorize what vessel is where in which view. And the concept that I'd like to convey to you is that the anatomy is very simple if you understand the structure of the heart, the structure of the coronaries relative to the structure of the heart. And then when you're picturing it, if you picture this ice cream cone model, you'll be able to very easily understand which vessels are going where and why. Okay? So here's the left ventricle. It's no longer an ice cream cone. Left ventricle, sitting on top of this would be a ball of ice cream. That would be the left atrium. Sitting on top of the right ventricle would be a ball of ice cream. That would be the right ventricle. And the anatomy is such that these two structures are sitting in the chest, and the apex is to the left, inferior, and a little bit anterior. That's why the apical impulse is palpable. But this is where the heart is sitting. Okay? We have a very thick-walled left ventricle and a thin-walled right ventricle. And because they're glued together and the left ventricle is the stronger muscle, the right ventricle actually wraps around like this. So the right ventricle is more crescent-shaped. The left ventricle is more concentrically shaped. Okay? So let's say you had this ice cream cone heart, and you wanted, which you'd have to do if you were God creating the heart and the circulation, you'd have to come up with a plan for supplying blood flow to the heart. So what would be the ideal way to do that? Well, one is, and probably the most logical if you were just going by logic, would be bring it in. Simplest thing is bring it into the apex and then have it fan out to the front, sides, and back of the heart. That would make sense, right? Yet evolution didn't allow that. And the reason evolution didn't allow that is one vessel would jeopardize the entire heart. If that one vessel is lost, the organism dies. So that's seemingly a pretty simple way of doing it, but it's not a very evolutionary, reasonable way of doing it. You have to have some safety mechanisms, And of course, as the circulation of the heart evolved, it evolved these mechanisms. So another way of doing it seems a little more complicated, but a little safer, and that is to somehow bring the arteries, the blood flow, to the rim of the ice cream cones, and from there have them descend front, sides, and back. Okay? And that way you have a lot more safety. You're not, one vessel isn't going to lose at all. And the additional safety feature is that since the rim is bigger, you could have more than one vessel coming to the rim. And that's why we have a left coronary and a right coronary. But when you put the two together, they circle this ring. So what we're going to do is put this ring together. And here's this confusing looking left coronary artery, and here's this simpler but also confusing looking, look like they don't belong together. But when you bring them together, there's your ring circling the outer part of the ice cream cone. And the branches all make immaculate sense in supplying the front of the heart, the back of the heart, one side and the other side. And so if you took your ice cream cones and put them in this structure, this is what it would look like. So here, if you can picture this, is the left coronary on my left, right coronary on my right, the arteries that are supplying the front, the back, and the sides. Okay? So that's the concept, and that simplifies things. If you picture this ice cream cone model for the heart. Okay? Make sense so far? So what we'd like to do now is say, let's take away one of these, right, and focus on just one at a time. So we're going to take away the right coronary and focus on the left coronary. Remember that the heart is oriented apex left, inferior, and anterior. So the coronary arteries are sitting like this in the chest. And this is important when we start visualizing it, and we'll be projecting it. But first, let's talk about the anatomy of these branches. Number one, and of course the most important, is the left main. While it doesn't supply 100% of the heart, usually supplies about 2/3 of the heart. The left main can be variable length. Rarely, but not zero, is it separated where the branches of the left main, where the left main does not exist, and the branches come off the aorta. That's in the neighborhood of 1 or 2% of people. But everybody else has the left main. The left main may be a millimeter, it may be 2 centimeters in length. We don't think of the left main as having any branches, but the left main can have a branch or two, and that branch or two goes to a structure. So here's our left ventricle and right ventricle, and what's the structure that comes out of the right ventricle right next to the left main? It's the pulmonary artery, pulmonary artery running upward. So there are branches of the left main or the left anterior descending that supply the conus. These are not prominent branches, but can play a role if you have a connection to the pulmonary artery. And so these become fistula, very large, but they arise either from the proximal LAD or the left main. So the left main does have branches, they're just small and we don't pay attention to them. The left main bifurcates. And this model sort of shows the general configuration of that bifurcation, and it's again in keeping with this ice cream cone concept. The most important artery in the heart is the anterior descending. And the anatomy of the left main and anterior descending is such that generally it's a direct path. There may be some angulation of the anterior descending, but typically it's like this. Left main, anterior descending. Now the only, and the purpose of that evolutionary wise is that it's the most important artery. You don't want bends or turns or angulations where plaque tends to deposit. So the left anterior descending is more or less a direct continuation of the left main. The downside to this is something that is rare, but it is the downside to this direct pathway. And anybody have an idea what that might be? In embolism to the coronary artery. The circumflex almost never gets an embolism. The right can, but the most common is the left anterior descending. The reason is if it gets to the left main, which is the biggest orifice, once it's in the left main, it's going to go down the anterior descending. Unfortunately, these are uncommon events. So let's focus on the anterior descending. The anterior descending has two responsibilities. Again, if you take the ice cream cone concept, those responsibilities are easy to see. So here's our ice cream cone, our left ventricle, and here's our anterior descending. So one responsibility is to provide the anterior wall of the left ventricle, but the other responsibility is to provide the septum separating the right ventricle from the left ventricle. So it has dual responsibilities. And how it does it is variable, but it always does it. So let's look first at the septal. The septal branches can be variable, but typically the most prominent would be the first or the second. We think of it as the first, or S1, as usually the largest, but that's really not the case. And alcohol septal ablation has taught us a lot about septal anatomy, but very frequently the second septal, which is more the body of the septum, is more prominent. But it doesn't really matter. There's one septal, two septals, providing the major portion of the septum, and then there may be several others downstream providing the more distal septal. But the first septals are most important because of the structure that runs in the septum, basically from near the confluence of the base of the septum, and those are the conduction system, the AV node and the left and right bundles. Okay, so the septum, first and second septals, are very important for conduction. Acute MIs that cause complete heart block will be very proximal acute MIs that wipe out these septal branches, and those are very high mortality. The septum also is off the septal branches off the left anterior descending is more important than the septal branches coming off the posterior descending. The septal branches off the anterior descending, we say, supplies about 2/3 of the septum. The branches off the posterior descending provide maybe 1/3 of the septum. So again, this duality of blood supply to the heart has this evolutionary advantage, but the anterior descending is by far and away the most important. So the second function of the anterior descending is to supply the anterior wall of the left ventricle, anterolateral segment of the left ventricle. And it does that with the only artery that is named after its appearance and not named after its territory. Anterior descending is named after its territory. Septal is named after its territory. But the branches of the anterior descending that supply the free wall, the anterior wall, are not called the anterior wall branches. They're called the diagonal branches. And they're called the diagonal branches because anatomically they arise at a diagonal from the anterior descending. This is good and it's bad. Because this is such an important artery, the more direct the path, the more reliable the arterial blood flow. But from the interventionalist standpoint, the origin of the diagonal and the bifurcation, because it's the fork in the road, can be a common source of plaque deposition. And from the interventional point of view, when you have an acute angle, a diagonal angle, working on one shifts plaque onto the other, as opposed to working on other branches that are at right angles, where you could get a balloon and a stent to go into the artery with minimal involvement of the mother branch. You could hardly do that with the diagonal. That's why diagonal bifurcations, or LAD diagonal bifurcations, are particularly tricky interventional procedures. Now the diagonal, as the septal branches, are variable. Most common, but not universally, the first diagonal is the most important. Occasionally we'll see a little twig as the first diagonal, and we ignore that. But occasionally we see a big twig and a big second diagonal. And in that case, the second diagonal is the more dominant one. So that variability is there. But almost always, the first or the second diagonal are the most critical branches for the free wall of the left ventricle, for the anterolateral segment of the left ventricle. Okay? But the diagonals can be varied in how many there are. And if you look really closely, you'll see diagonal branches coming almost all the way down, even at the apex. So far, so good? Now, there's a couple of little twists here. One is a type of variation to the left anterior descending that actually is a pretty good variation. I don't know why it didn't catch on over the millions of years of evolution of the human heart, but that is a bifid LAD, what's called a bifid LAD. Left main comes, gives rise to the LAD, and then the LAD immediately separates into two vessels. Both run on the front of the septum. So they're both anatomically in almost the same location and run parallel to one another. The bifid system allows a division of responsibility. One of the bifid branches supplies just the diagonals, and the other supplies just the septals. Would make a lot of sense that this would be, but it is another branch. Maybe that's why it never really evolved. But it is important for you to recognize and describe it, and not to glibly call it the left anterior descending, or to glibly call it the diagonal. The reason that it's important to recognize is that, let's say there's disease in one or the other of these bifid LADs, and you're sending the patient to surgery to bypass the LAD. I wouldn't say more often than not, but you will, in the course of your careers, run across lemas placed to the wrong one of those two. So one runs on this side of the septum, one runs on the other side of the septum, both very close together, and the surgeon has to be made aware that you're talking about the diagonal portion of the diagonal of the LAD, not the septal. And if you just tell him it's a diagonal, he may bypass a diagonal but not bypass that particular vessel in total. Okay, so that's one variation of the LAD that we see quite a bit of, and it is important to recognize, one to name it and the other for the functional importance in sending patients to surgery. There's another variation of the LAD that is important, and that is the length of the LAD itself. The LAD, about 2/3 of the time, makes its way to the apex of the heart. So it supplies that portion of the left ventricle to the apex. 1/3 of the time, it runs around the apex. And it actually does some of the work that the posterior descending should have done. And in those cases, the posterior descending is usually small, short vessel. The anterior descending runs around. Clinically, what's the relevance of this? Patient comes in with a STEMI, and the STs are elevated in V2 through V6 and 2-3 in AVF. You look at it, what is this? An anterior infarct, an inferior infarct. Does it mean that the right occluded and the left LAD occluded at the same time? I mean, that could happen. It's just so unusual for that to occur simultaneously. So what is that when you see that? That's a wraparound LAD. Okay? And that's important because that's an extensive infarct, and you got to hop on that very, very quickly and thoroughly. But that's a huge infarct, but that's the cause. Anterior and inferior a wraparound LAD. So 2/3 of the time it comes to the apex. 1/3 is additional. I'm confusing you a little bit. 2/3 it's to the apex or around. Okay, 1/3 it's around. So 1/3 it's to the apex but not around. So we're missing 1/3. In about 1/3 of patients, it doesn't reach the apex. And in those patients, the posterior descending branch is the one that should come around. But in some, the posterior descending doesn't quite come around. So the apex has a relative potential deficiency, and this is a cause of false positive stress tests, where at high levels of exercise the apex is actually ischemic, but the coronary arteries are normal. And that's because the posterior descending didn't do its job of making up for that short LAD. The LAD still has the septal responsibility, diagonal responsibility, but it didn't quite fill its apical responsibilities. Okay? Clear so far? Okay, now we're going to look at the circumflex. The circumflex is not a direct continuation of the left main, typically. To get to the circumflex, you have to make a right angle turn, or close to a right angle turn. And if you look at enough coronary angiograms, you'll see that that really is true, that the left main goes into the anterior descending. If you look at the an LAO caudal view or an apical view, it looks like this. The circumflex, left main circumflex comes off at an angle. So that just means it's a little less important in the hierarchy of coronary arteries. But it does have a single responsibility. And the single responsibility of the circumflex is to provide blood flow to the lateral wall of the heart. That's its single responsibility. How it does it is quite variable. So why do we call this the obtuse marginal artery? Well, the reason we do is because, as I mentioned before, most arteries are named by where they go to. And if you look at the heart, there are two margins. Here's your front, here's your back. Those aren't margins. Your margins are the lateral wall of the left ventricle, lateral wall of the right ventricle. The lateral wall of the right ventricle, because, as I said, wraps around, that angulation is a little more acute angle. The left ventricle, because it's a thick muscle, is very concentric. So the angle of the margin is more obtuse, this more acute. So that's why this is called the acute margin. This is called the obtuse margin. This is called the obtuse marginal artery. And the circumflex can supply this obtuse margin in several ways. One is through an obtuse marginal artery that could arise midway down the circumflex. It could arise very proximally on the circumflex. Rarely does it arise distally and go backwards. That's not a very common thing. But the circumflex supplies the obtuse marginal. Now, occasionally you'll see a very small circumflex. In that case, you'll have a different way of supplying the obtuse margin, and that's with a third branch of the left main, which functions as an obtuse marginal, and that's called a ramus intermedius, or a ramus, or an intermediate branch. So the ramus is essentially a very proximal circumflex branch. Now the circumflex has some options. What is not optional is supplying the obtuse margin. But it does have some options in how much of the posterior wall, a posterolateral wall of the left ventricle, it supplies. And there may be one, there may be two branches that are more posterior in location and are called posterolateral or posterior ventricular branches. And in a minority of cases, the circumflex goes all the way around and supplies the posterior septum, and in that case we say it's left dominant. So it can provide a posterior descending in a minority of cases. Okay, so circumflex, obtuse marginal can be one or two. Posterolaterals are optional, can be one or two or three. Posterior descending is even more optional, and in that case, it either shares responsibility with the right, in which case it's codominant, or it's the right has gotten rid of its obligation and it's a left dominant system. So that's the anatomy. That's essentially the main variabilities. So now we're going to take this ice cream cone idea and we're going to try to simplify coronary angiography. Okay, this looks kind of confusing. But let's do this. Let's take our heart and let's put it in the anatomic position. Okay? So here's our anatomic position with the apex to the left inferior and anterior. And let's visualize it. So this would be an AP view. Now, we often will get an AP view, but because of the overlapping of so many branches, by itself, it really doesn't help us in either anatomy or in lesion assessment. So we have to do something to separate the different parts of the left coronary artery that we want to visualize. Now, years ago, we had cath labs in which the patient was sitting on a cradle and the cradle rotated this way or that way, but the image intensifier was in its fixed spot. Okay? And so the original views that were utilized that limitation. So what do you do to improve given that limitation? Well, two things. One is that you could bring the image intensifier over the left chest. That's called left anterior oblique. Or you could bring the image intensifier over the right chest. That's called the right anterior oblique. If you bring it over the left chest, let's do that. what do we see happening? Well, we're separating the anterior descending from the circumflex. Okay, not perfect, but we're getting a little bit better view of the circumflex. We're getting a little bit better view of the branches of the circumflex, but we're getting to see that rim of the ice cream cone, that circumflex, a little bit better. The anterior descending, we see some of it, but here's the rub. This is the origin of the anterior descending. Now I'm now about 2 centimeters down. Hardly looked like it moved, right? 2 more centimeters down. Hardly looked like it moved, right? If I show it to you how much I moved, and what is this phenomenon called, where vessel is coming out at you and its length is shorter than than reality? That's called foreshortening. So the disadvantage of this fixed left anterior oblique view is that we really didn't get a good view of the proximal anterior descending. The branches of the circumflex are more or less coming out at you also, because the apex is coming towards you. And so it was helpful and we used it, but it has significant limitations. So let's take that other view. Remember, here's our anatomic position. Let's take that right anterior oblique view. In this case, what we're doing is we're profiling the heart with the apex to that side of the screen, and it highlights the anterior descending, right? So now you see even that proximal portion, you see it well. You see the body of the anterior descending. But what's the problem here? The problem here is that there's overlapping of branches. The diagonal gets in the way. So this view by itself helped us with the anterior descending, but it didn't really give us clarity of the anterior descending branches. What did it do on the circumflex? Well, now you have foreshortening of the proximal part of the circumflex. You have foreshortening of the distal part of the circumflex. But you got a better view of the posterior descending and the branches of the circumflex. Okay, so we're still limited in our full assessment of the coronary arteries. Again, remember that ice cream cone. So now let's see what we could do to improve on this. Anatomic. Well, let's say you were able to sit on top of the heart, top of the chest. Wouldn't that be nice? Here we have the anterior descending, and here you see that entire anterior descending, diagonal branches, just beautifully. We're sitting on top of the chest. How do we sit on top of the chest angiographically? Well, we could bring the image intensifier sitting on top of the chest, but better yet, we bring it anteriorly so it looks like we're dipping the heart down. And this is the cranial views. We're bringing that image intensifier towards the head. Okay? Now, the one thing that I want you to go away, if there is one thing that you get out of this lecture, is that, and as we'll demonstrate, if you want to see the anterior descending completely, it's the cranial views. If you want to see the circumflex completely, it's the caudal views. So let's look at that. Here we have our anatomic view, okay? And we're going to make it AP cranial. And we've done a lot to improve the anterior descending. We've separated the diagonal branches. The circumflex can get in the way a little bit, but depending on how we angle it, you get the circumflex out of the way. And one thing to remember is that if you're still not sure of that proximal anterior descending, you go more and more cranial. Watch this. The more cranial you go, the more you see the origin of that anterior descending. Okay? So one view is never enough, so let's take that anatomic view and let's make it a left anterior oblique cranial view. And that's about what this does. So left anterior left anterior oblique cranial view. Now what that does, that's really a good view of the anterior descending. I think that's what I was kind of showing more of before. The only problem with this view is structure that sits right behind, and that's the spine. And in big people, you have a liver that's right below, and the shoulder up here. So you have to penetrate a few soft and hard tissue masses. So sometimes this left anterior oblique cranial is a very nice view, but we have to manipulate it until we get off the spine. Sometimes we can, sometimes we can't. One thing that's helpful is at least to have the patient take a deep breath and get the diaphragm out of the way. The spine is still there, but get the diaphragm out of the way. Okay, but again, cranial views, anterior descending. So now let's go to anatomic right anterior oblique. Right anterior oblique, and now we're going to make it right RAO cranial. And so here we have essentially what you see. Maybe the circumflex is a little more in the way in my angulation here. But what do we see? We see a very nice picture of the left anterior descending proximally. We're able to get the diagonals to go upward. And it's another way of seeing that anterior descending. And depending on an individual patient, either the AP cranial or the right RAO cranial will give us the best shot of the proximal portions of the LAD and diagonal. Okay, LAD cranial views. Always picture that ice cream cone. Yes, we don't penetrate this ice cream cone, but remember that you're making it like this, or you're making it like this. Again, that ice cream cone pattern. So let's look at the circumflex. We don't want to ignore the circumflex because it is, though less important, it is, it does supply the heart. So here's our anatomical view. And I said if we take the anatomic views and we get the anterior descending out of the way, Well, how do we get the anterior descending out of the way? We have to lift the apex up. How do we lift the apex up? We bring the camera towards the pelvis. So, anatomic view, we bring the image intensifier down, and that brings us like this. So this is the AP caudal view, and it should be a beautiful view, it is, of the circumflex, good view of the marginal branches, good view of the posterolateral branches, and typically a pretty good view of the posterior descending. It's a little foreshortening. We want to see that a little better. We go LAO, anatomic LAO, and make it caudal angulation. And now the apex is coming straight at you. And we're seeing the rim of the ice cream cone very clearly. And again, the ice cream cone configuration is clear now. Okay. Circumflex, the rim. Obtuse marginal, posterolateral, posterior descending. But in this view, those branches are foreshortened. They're coming out at you because the apex, remember, they're descending towards the apex. So they're foreshortened. But it's a wonderful view for working on the origin of the circumflex, getting into the branches, and seeing the full extent of this vessel around the rim. Okay? But we want to work on the branches. There's more disease in the obtuse marginal, in the marginal branches. So let's work on that. So here we have anatomical view. Now we're going to go RAO, and then we're going to bring our image intensifier to the pelvis. So we're raising this up. So now, look at how nice that looks. Circumflex, we see essentially the entire body of the circumflex. We see the obtuse marginal lesion here. We're going to easily see it and work on it. Posterolateral branches and posterior descending. It can be a little confusing because it's a little unclear which is the posterior descending, so you change that angle a little bit. Change the degree of cranial angulation. Okay? So one of the morals of coronary angiography is that before you finish, get in your mind, and if you have to review, get in your mind whether you've seen all the vessels and the origin of all the vessels before you pull out the catheter. There's nothing more traumatic to you and the patient than to finish and say, oh my God, I think there's a lesion right at the origin of the obtuse marginal. We never got a good view of it. So always review, and some people with experience, as you're doing it, they see all these things. But if you're relatively new, no problem with stopping after you shot what you consider the left coronaries and reviewing those pictures and making sure you've got everything. You don't want to go back and do another procedure. And it is crucial to know, is there a lesion? How bad is the lesion? Okay, so we're not going to do the right today, but next time we'll have the angiograms. We'll do a quick review of the left and look at the angiograms, and the right, which is much simpler, we'll do the anatomy and the angiography. Okay, clear as a bell, clear as mud. What is it? Okay, thank you.
I just wanted to ask the fellows,
Yeah.
We work towards that.
Well, one of the things you mentioned, which I think is a good idea, is since fellows rotate, we could repeat
Right.
this kind of lecture, every 4 months or 3 months, every quarter. And then there might be some sessions when we might just show coronary angiograms and just discuss the vessels, just pull anything off the shelf and just...
Right. So maybe, first year or second year fellows, they can volunteer, meet the angiograms, step by step,
Yeah.
step by step.
Yeah.
And over a period of time, maybe a normalist coronary
Yeah.
angiogram. So like that will sort of create a system of, remembering and reading them in a systematic way.
And one of the things that I always try to do when I do a case is sit down afterwards and go through the images. Now, and if you're doing a case and you're going through the images, make sure that the attending will go through these with you, and if there's something unclear, clarify why he thinks it's what and view. So you could learn a lot. We tend to assume everybody knows the things that we've done after doing 10,000 of these, but it really isn't the case. So grab whoever you're working with by the throat and say, what is this branch? Why'd you call it this? And that's how you learn. Okay. Remember the ice cream cones.